other physician is able to get next day visits. They're able to spend up to an hour or even more.
We here at HealthWise, we focus a lot on lifestyle medicine. I also see some patients that we treat for the disease of obesity. Can you tell me how obesity affects fertility in general, and even some of the IVF procedures that you all may do, or any of the reproductive technologies?
Absolutely. I mean, obesity, it's an epidemic in the United States. And yes, there's a lot about obesity and fertility. Even, let's take it from a couple's perspective, because we also deal with the male as REIs as well too. So let's talk about the woman and how obesity can affect her fertility. So in women who are obese, you can have a situation whereby ovulation is affected as a result directly from obesity, right? So women who are obese have a higher rate of having anovulatory cycles compared to women who are not. Okay, so we also know that there could be some egg quality issues in this women who have obesity, because we see circulating higher levels of free fatty acids in the follicles of this women surrounding the eggs. So women who are obese have higher rates of egg quality issues, higher rates of anovulatory cycles. And then unfortunately as well too, women who are obese, if they get pregnant, just because of the obesity, have a higher rate of miscarriage. We know that obese women, interestingly, make similar rates of euploid embryos, that is, embryos that have the normal chromosome complement. But despite the fact that they make euploid embryos at the same rate as a non-obese women, they suffer higher rates of miscarriages, which we think might have something to do with just the environment in the obese woman surrounding pregnancy. So what are some of the counseling things that we discuss with women with obesity? It's a battle between age and obesity. In a young woman who is very obese, otherwise has normal ovarian reserve testing, no true concerns from that standpoint, it is reasonable to go through a period of medicated weight loss, right? Medicated weight loss, because we know that even in those women who are obese and have concomitant anovulation, that even losing just 5 to 10% of their current body weight, sometimes that ovulation goes back to normal and they start ovulating pretty regularly. And, they might not even need the help of a reproductive endocrinologist. They may be able to spontaneously ovulate and get pregnant and have no issues down the line. So sometimes we can go through that process of medicated weight loss in those patients, or even lifestyle intervention if they're not interested in medications at that point in time to try to lose some weight before continuing with their fertility journey. It becomes trickier when we have women who are advanced maternal age and are obese, because certainly that age effect is just so powerful that we can't ignore it. We sometimes have to push forward at that point in time with fertility treatment in women of advanced maternal age, because the effect of the age is just so powerful that we cannot delay things any further. So that's how obesity is, that's how I counsel patients about obesity when I see them for a fertility consultation. Men as well too can have some issues as a result of obesity. One of the thought processes that in terms of how that could happen is that when a man is obese, it sometimes raises the temperature of the testes, which is supposed to be at a lower temperature than the rest of the body, and that could impact spermatogenesis and result in the formation of abnormal sperm. So, again, going over those weight loss strategies could be beneficial for the male partner as well too, in terms of improving male fertility.
Yeah. So thank you for that. Very helpful information. And we often counsel our patients that even a 5% weight loss, like you said, can really change a lot of health conditions. And it's good to hear that that even affects fertility.
Absolutely, absolutely. Especially if there's an anovulatory component. It's, they lose that weight and the periods become more regular. It's not unusual for me to hear that, oh, when I lost, 10 pounds, 15 pounds, all of a sudden my periods that were irregular before started to become more regular. And then I started to get symptoms like I was having, going to ovulate, and that my periods were coming, really malignal symptoms, which is reassuring typically in those patients. And I even take it a step further. That weight loss, it's not just about even getting pregnant. It's also the health of the pregnancy when you do get pregnant, because we know that weight loss can be beneficial in terms of reducing obstetrical complications as well too when patients are pregnant.
Absolutely. And thank you for pointing out that end goal, because again, our end goal is a healthy pregnancy.
That's right.
So I want to talk about something that you touched on a little bit with some of the previous topics that we talked about. You talked about, basically male factor infertility, and some, of course, when patients come to you, sometimes they come to you, the male and the female come as a partner for consultation. Can you kind of discuss a little bit about how male factor infertility plays into what you do, and you just kind of give some of our male audience some things that they can do to prepare for a visit for a reproductive endocrinologist, or if they're suffering from infertility as well?
Absolutely. So we know that a male factor can be contributory to as much as 35% of infertility. So, I always say this, and I joke around when I see my couples, is that, oh, the man is not going to get away without at least a semen analysis. That's something that's routinely done just because of those high rates, right? In which they could be contributory. So I think, when the couple presents, what they should expect in that initial consultation is just me trying to get to know them. Right? Just trying to get to know them, trying to identify any risk factors that they might have. So the man should come, the woman already knows that I'm going to get the entire history from her. The man should come prepared as well, too, for me to get their entire history as well, too. I want to know if they had any surgeries when they were a little boy, because it's not unusual for men to not know that they may have had a hernia repair as a little boy, which is something that, might be that we might want to investigate further as a result of how we could relate to fertility. So getting that history from them. I also do get a thorough social history from the men, any medications or supplements that they might have been on, because sometimes, especially people that, do a lot of exercise, might have been exposed to some anabolic steroids in the past that can certainly affect their fertility status. So medication supplements is very important. I ask about ejaculation problems and erectile dysfunction. I ask about any significant medical history that they may have, any surgeries that they've had in their past. And I also alluded to tobacco, alcohol, and drug use. So marijuana is a big one out there that we know that could affect a man's fertility. And then obviously they've had, if they fathered a child in the past, it's something that would be helpful to know. And then if they've had any type of sterilization procedure, like a vasectomy. So those are things that, I try to get from the history of the man. I also try to get a family history to see if there's anything in the family history that might suggest some sort of genetic condition that could predispose to infertility, or the birth of a child with some sort of genetic condition. So those are things I elicit from the male part when I see them for the initial consultation. And men, routinely, I always recommend the basic evaluation, which is a semen analysis. Now, we can get into the disadvantages of the semen analysis, but as we stand now, that's the one test that we can recommend for the man, and at least know basically whether their sperm parameters can result in a pregnancy in a woman.
Yeah, that's awesome. Would that be something, a semen analysis, would that be something that you recommend that our male patients have done while they're waiting for that consultation with you?
Absolutely. Like if they can, we like to use the WHO-5 criteria for evaluating it. So if they can get a lab that can do that for them, I think the WHO-6 criteria is out now, but most people are still doing the 5 as we speak. So if they can get a lab that can do that, then that would be great. It's just sometimes finding the lab that can do that for them.
Perfect. Thank you for sharing that, because I know sometimes some of our male patients don't get access to that information. So I'm taking notes, because that's really, really great information for our couples.
Yeah.
So now I have a few questions, and sometimes patients, ask us questions that they don't really feel comfortable with talking to, any of their other physicians about, because we have a comprehensive care approach here. So I'm going to just ask you some of the questions that we've been asked. So I have a question about specific sex positions. Are there any specific sex positions that increase your ability to conceive? So the answer to that is no. So, okay. So that's kind of an old wives' tale, I guess I would say, so that some of the patients have asked about. And it's been asked, more than once. So, Yeah. So now the other question that I have for you, because you've talked about the age-related kind of rate limiting factor for fertility treatments. At what point would you recommend that a couple seeks either the help of their gynecologist or even a reproductive endocrinologist when they're trying to conceive?
Great question. So it's really dependent on the age of the woman. Women under the age of 35, either they've been trying to get pregnant with a partner consistently for 1 year without success. Between the age of 35 and 40, it is shortened to 6 months because of that age-related decline in fertility. 40 and above, it's almost like an immediate thing because the age-related decline in fertility is so powerful that at that point in time, we recommend that you at least seek care with a gynecologist just to make sure that there isn't anything preventing you from getting pregnant. Now, there's specific clinical scenarios in which this time limits don't apply to you. If you're a woman that has irregular periods, then you should seek care right away because that is already a risk factor that you are not ovulating. And if you're not ovulating, there's very little chance of you getting pregnant unless you have a skip ovulation in a month. So in that situation, anovulatory periods, not having regular menstrual cycles, you want to seek care right away. There are also some specific factors that would, make me recommend that you seek care pretty quickly. If you have very, very painful periods suggestive of underlying endometriosis, we know that endometriosis can be associated with infertility. So I would recommend at that point in time that you see a fertility doctor, or at least start with seeing a gynecologist. Other things are if you've been exposed to treatments that could be gonadotoxic, that is toxic to the ovaries. So, for example, a woman who had a history of having had chemotherapy for some cancer previously, I would recommend that they seek help sooner rather than later because we know that the chemotherapy can be very damaging to the eggs, to the number of eggs that a woman has in her ovaries. So, in that situation, I'd recommend that they seek care sooner rather than later. So it really depends on the clinical scenario in this patients, because if they have risk factors, then I recommend earlier care than compared to those who don't have any risk factors.
Yeah. So I just to clarify, this is even in our 25-year-old who maybe has anovulatory cycles, they really should seek care from at least their gynecologist and see if they're a patient for referral for a reproductive endocrinologist.
That's right. And 25-year-old patient has irregular periods. I mean, I would certainly recommend that she starts with seeing her gynecologist because perhaps all she needs at that point in time is some letrozole for ovulation induction. But yes, it's a big risk factor if you're not ovulating at that point in time because you have very little chances of getting pregnant if you're not ovulating.
Perfect. Perfect.
Yeah.